Research in Progress webinar series. I'm going to give just another minute or two before we get started, as it looks like people are just now coming into our Zoom room. So just hang on with us for another minute or two and we'll get started. Well, again, welcome everybody. Thank you for joining us for the Systems for Action research program in our regularly recurring Research in Progress webinar series. For those of you who might be new to S4A, Systems for Action is a research program of the Robert Wood Johnson Foundation. Our mission is to study innovative ways of helping medical, social, and public health delivery systems work better together to tackle issues of health and especially health equity in American communities. We fund a whole variety of studies all around the country, testing innovative ways of connecting and aligning systems across sectors. And we use this webinar series as a chance to feature one of our research teams and to learn about their work and what they're learning, and thinking about how to move evidence from these studies into action across American communities. Today we are very excited to feature a research team based at Cornell University, the Weill School of Medicine, and this is a recently completed research study, and we feature research teams kind of at all stages of the research process, and we'll be hearing from a research team today that has recently completed work and has been working on developing tools for disseminating and putting their evidence into action. And so with that, let me just say a little bit of housekeeping. We will definitely have time to entertain questions from the audience for today's webinar. Encourage you to think about questions that you may want to ask our research team today. At any time during the webinar, you can type in your questions into the Q&A box feature of Zoom. You should see a button down at the lower part of your screen in the center that says Q&A. Click on that box, type your question in. Do that at any time, and then when we get to the Q&A portion, we will get through as many of those questions as we can. So keep that in mind. Also, we'll let you know, as we always do, we do record these webinars, and we'll post the recording along with a copy of the slides onto the Systems for Action website for those of you who may have colleagues who can't join us live and may want to view this webinar at a later time. So definitely check out our website, systemsforaction.org. You can find the Research in Progress webinar portion of the website and access the recorded webinars there. And I think for everybody who has registered for today's webinar, you'll also get an email after today's webinar with links to those recordings. So with that, I'm going to turn it over to our research team for today, Dr. Yuha Bao, who is a faculty member at Cornell, and I'll let her introduce the rest of the research team and colleagues.
Great, thank you, Glenn. Can everybody hear me okay?
Sounds great.
Okay. Great. So we're very glad and excited to, share our research, recently completed research. I guess research never completes. about payment design tool for coordinated specialty care. I'll tell you a bit more about what coordinated specialty care is and what the system alignment problem that we address. My name is Yuhua Bao. I'm an associate professor at Cornell Medicine in New York City. And a lot of my research focuses on aligning incentives and systems, and especially payment policies, with evidence-based, patient-centered mental health and substance use care. And I'm really glad today that to have Monica Luke, a mental health advocate in the state of Massachusetts, join me today to share a lot of her insights. I learned tremendously from her and other people in this really bringing kind of the ideas to the real world and then tackling, making changes. It really takes a village, and appreciate funding support from Robert Wood Johnson Foundation, and in particular System for Action program. And our research benefited a lot from collaboration and data from On Track New York, which is New York State's implementation of coordinated specialty care, and our highly interdisciplinary team from several institutions, including Cornell, Columbia, New York State Psych Institute, Mount Sinai, and Hunter College. And many, many participants in our stakeholder engagement sessions and user tests of the tool. And last but not least, this national group, it's called PEPNet CSC Financing Work Group, that I've been part of for the past quite a few years, at least 2 and maybe 3 years. And this is a group of inspiring people who are devoted to, having CSC financed and covered by insurance, but also in kind of fighting for, a sustainable kind of financing systems for mental health services. So that's Monica is one of them, and that's how I got to know her. So we'll definitely come back to this group more. So game plan for today, I'll start by, since we've presented in this research series before a few times, but I'm sure that among the audience there are people who are hearing about it for the first time. So I'll talk a little bit about the system alignment problem, our journey with the CSC payment tool, with a video, and some insights that we gleaned from dissemination of our tool, which I think is going to be the highlight of today's talk. And then I'll hand it over to Monica, who will tell you about her journey with mental health advocacy, and what they are doing in Massachusetts to get CSC paid for. And then we'll open it up for everybody for open discussion and Q&A. So coordinated specialty care is a new treatment paradigm for early psychosis. So over the past decade, about a decade ago, the National Institute of Mental Health, NIMH, spearheaded research efforts to develop kind of early psychosis intervention programs to address needs of people who are in the very early stage of psychosis, which is a very, as you all know, a disabling condition, very serious mental illness. And so as part of that effort, this coordinated specialty care is kind of comes into being, comes onto the kind of the main stage of early psychosis treatment in the US. It embodies a few principles, including recovery orientation, shared decision making, a team of specialists, both clinicians and non-clinicians, and also with a very distinct objective to minimize duration of untreated psychosis, which is linked to worse outcomes. The duration of untreated psychosis is linked with worse outcomes lifelong for people with psychosis. And corresponding with the set of principles, CSC typically contain a key service, a set of key service elements, including case management, supported employment and education, and family education and support, psychotherapy, pharmacotherapy, primary care coordination, and community outreach and engagement. And as you can see here, that of the list, not many, those who are bolded, if you think about it, they do not have existing payment mechanisms in our, kind of traditional health insurance system. So the kind of dissemination and implementation of CSC in the U.S. fragmented healthcare system becomes, the long-term sustainability will be an issue, even though in the short term, starting from 2014-15, Congress earmarked, funding from the Mental Health Block Grant specifically to support national implementation. With that backdrop, we know that mental health block grant funding jump-started national implementation. However, it is seriously inadequate for population-wide deployment. So far, it's still, a patchwork approach that's being adopted to CSC financing. There has been increased interest, and therefore, in payment innovations, and to seek kind of insurance coverage of CSC with, for example, a bundled payment that comprehensively covers the cost of CSC so that the team can operate and be self-sufficient, and encourages patient-centeredness and therapeutic innovations, with the idea that the providers and their patients and families, they know the best about what to do, what a patient wants, what their personal goals are, and how to help them meet their goals. So it's best to leave the specific care delivery into the hands of providers and patients and families. So how do we design a payment model to really support those twofold objectives? So our team kind of anticipated a need for decision support for bundled payment design for CSC, quite a few years ago. I'm thinking, around 2015, 16. And specifically, when we talk about a bundled payment or a case rate payment, immediately you would be confronted with questions such as what services are bundled, how much should the case rate be, but also how do we build in accountability for client outcomes given the recovery orientation of CSC. So all these point to decision support, and one size does not fit all, because all these decisions need to be based on local circumstances, but also allow for a lot of flexibility. And hence the idea of a tool, so that for decision makers to play with. Here's our a sketch of our journey of turning 17 to 18. We were awarded a one-year pilot from RWJ System for Action to develop a tool prototype, and we engaged payer stakeholders in New York State, and basically Medicaid managed care plans, who actually told us that you guys need to talk to providers of CSE. And they are probably more important stakeholders to engage than we are. And we listened to them, and we went on to apply for a 2-year grant from System for Action again to continue our work. And thank you, S4A, that we got the award and we continued our work. And in this time, we engaged 19 CSE programs. These are provider stakeholders from a total of 14 states. We conducted engagement sessions, showed them a prototype of the tool over summer of 2019 to winter of 2020. And that informed our iterative refinement and implementation of the tool into a interactive online kind of tool that users could play with. And over the past 2 years, we conducted user tests with largely provider stakeholders, but also, as we will talk about later, public stakeholders. We did debugging and further refinement of the tool design over some time, and then we conducted very targeted dissemination efforts to the stakeholders that we believe are the right ones, the right stakeholders in, have vested interest in this, payment decisions. So a video is more than 1,000 words, and I promise that I will show you a video. And so here is a 3-minute video that will give you a better sense of what the tool does. And by the way, this is part of our dissemination effort. As you can see that it's on YouTube that we used to disseminate the tool. So enjoy.
Hello. In this video, we would like to walk you through an interactive tool. The tool will help you design an innovative payment for first episode psychosis programs, also known as Coordinated Specialty Care, or CSC. Each year, approximately 100,000 adolescents and young adults in the United States experience first episode psychosis. CSC is a team-based and a recovery-oriented approach for early psychosis interventions. Currently, financing of CSC can be characterized as patchwork. CSC programs typically tap into multiple sources of funding. They're often inadequate and unsustainable. CSC providers expressed strong preferences for a case rate payment. For example,
I absolutely think that a fee-for-service model will never work for coordinated specialty care. Moving to the case rate is absolutely the only way.
A case rate payment gives the providers a little bit more flexibility in how those services are provided, and I think really transferring that responsibility to providers is really the right direction.
But where would one start when designing a case rate payment? Specifically, what services are covered by the payment? How much should the case rate be? And how could one design it in a way to promote fidelity and client outcomes? All these questions point to the need for decision support. That led us to the idea of a tool to support local decision-making by CSC stakeholders. Next, we're excited to show you what the tool looks like and how you can make use of it. First, the payment design tool allows users to select which types of services they would like to cover by the case rate payment. Next, users will provide information on professional members of the CSC team, full-time equivalents of each member, and their hourly wage rates. The user will further provide the fringe rate, an indirect cost rate for the team, and team caseload. This information will be used to estimate the cost of providing CSC services and, in turn, to determine the payment rate. If a user chooses to include an outcome-based payment, he or she is presented with a set of client outcomes to choose from. The user will also decide what proportion of the case rate payment they would like to withhold as incentives for achieving client outcomes. The tool then provides a report outlining the payment design and the anticipated payment to the CSE program over a 12-month period. If you are interested in using this tool or simply wanted to learn more about this project, please contact us. Thank you.
Great. Thank you. So, okay.
Hello.
All right. I hope everyone can still hear me okay. So I'm gonna switch a bit to our lessons learned from the dissemination phase of our project. So who are actually using our tool so far, and what are they using it for? So originally we were thinking, when we were developing, we were writing the grant to Assessment for Action, we were thinking that maybe a dyad of payer and provider stakeholders could come together and use the tool to make collaborative decisions about CSE payment design and payment rate. We thought that that process would enhance kind of transparency and facilitate their discussion. Guess what? Turns out that that's not the case. That's entirely not how the stakeholders would use the tool. What we found in reality is that provider and public stakeholders are taking leading roles in exploring, bundled case rate payments for CSC, and they are taking leading roles, as Monica will tell you more about, in fighting the political battle, actually, to get it covered by insurance. So of the at least 14 individuals or institutions that requested access to the tool in our dissemination phase, we have 5 that are from CSE provider, that are CSE provider stakeholders, 5 are public payers, such as Medicaid programs, or state agencies, such as a state's mental health agency. We have 4 who are researchers and people who provide CSE tech support to states and to providers, and we have 0 private payers. And in fact, what I learned later by participating in a national group, national financing work group, is that private payers tend to play. They're reactive. They're not actively working on this. They're more of a reactive, in a reactive mode. But I hope Monica will touch on that more. And then how do they use? If they used it, how did they use it? Users who requested access tool invariably use it unilaterally, unlike what we kind of expected or hoped for. Providers would like to have an idea of the bottom line. What's the minimum rate that we would accept when we discuss the payment rates with a payer. They wanted to get a sense of that before going into negotiation with payers, which makes, from hindsight, makes perfect sense. And then state agencies turned out to be an important user group of our tool. And because of their perspectives, they're using the tool for planning purposes. And therefore, because when we designed the tool, we did not necessarily bear in mind their perspectives, a planner's perspective. So the tool may or may not adequately meet their needs. For example, in the case of Massachusetts, they played with our tool and they found it helpful, but they went on to develop their own version of a tool by adding a component. The added component is to map out the likely caseloads of patients at their, kind of existing CSC programs around the state, because they're a planner and they are concerned about whether the capacities they have now can adequately meet the needs of this, the early psychosis community in the state. And so, so that component, recall that from the video, the caseload is a parameter that we ask the users to input, right? So we assumed that they know, but from a state planner's point of view, they may not know, and they wanted to map out the different scenarios. So that's something that we learned from our dissemination. But more importantly, what I gleaned is, especially by participating in that national group, is so much more than a payment design. A payment rate needs to happen to get CSC paid for. So with that, I'll just turn to Monica Luke, our guest today, and for her to share with you much more than that. So let me stop share and give it to Monica.
Well, hello, and thank you very much for having me, and Yuha for including me in this. It's awesome to be able to speak with all of you about some of the challenges around getting financing for coordinated specialty care. A little bit about me is, after more decades than I might want to mention in technology, I became a mental health advocate about 6 years ago, with a focus specifically on getting payment models addressed for people with psychosis, because I have a son who has schizophrenia. And in that journey of trying to get him care, I learned that families like mine that have employer-provided insurance are in some of the worst positions, even in a state like Massachusetts, where we have a robust Medicaid program through our Department of Mental Health. If you can't reach into your pocket to pay for what you need, your healthcare is not going to cover that, whether or not your loved one is actually on your healthcare. And unless you qualify for public assistance, you don't get access to the Medicaid programs. So it's really actually kind of terrible to be in the middle, where you can't quite reach into your pocket and pay for everything you need. So I wanted to make a difference to families like mine going forward, to be able to get the care they needed. And along that journey, my son had his first psychotic break in 2001. So coordinated specialty care was not something I'd ever heard of. It was not available to him. But in the intervening years, it's become something that I see as a lifeline for other families like mine, that if we can get young folks into these programs as soon as possible, the outcomes that can be achieved are just really amazingly different than what we think can happen for someone diagnosed with a psychotic disorder. So payment is one of the biggest single barriers to that. And as someone who's a systems thinker, it was sort of a natural thing for me to start to tackle. So that's kind of how I got here. I also appreciate the technology aspects of the design tool, because as a technologist, it was very appealing to me. So here in Massachusetts, we're actually focused on a three-prong approach to attempting to get payment, full payment. So as was referenced in the slide with the bolded text, 2 out of the sort of 6 or 8 features of a coordinated specialty care program are covered in a fee-for-service model. So all of our programs here in Massachusetts are very creative about how they try to get that additional funding. Sometimes there's philanthropy drives, and folks will pay for the additional supports. Particularly school and job supports are considered a critical component of part of this evidence-based practice. And of course, our insurance companies require that we demonstrate that the programs we're doing are evidence-based. And at the same time, in the case of coordinated specialty care, they don't pay for all the components that get you that evidence. So it's kind of a very tricky catch-22 that we're sitting with here. So we use, some folks use philanthropy. The mental health block grant does have a set aside, but for the number of programs we have here in Massachusetts, it doesn't cover getting all of the additional care to all of the programs we have. I thought we had 18. Yesterday, I heard we had 21. So the number of coordinated specialty care programs in the state is somewhere between 18 and 21. And we sort of sprinkled the money around so that, 1-2 year period, this group gets enough money to have job supports or a peer support specialist. And next year, this other group of programs gets it. And plus, it's still not achieving sort of my objective, which is that, having coordinated specialty care be something that's available to the entire population that needs it, not just those who are eligible for Medicaid. And some places are using grants. They apply for grants into particular organizations. But in all cases, it's a patchwork. And that patchwork is really costly for many reasons, not just the complexity of it, but there's a lot of administrative overhead. So folks on the team who could be spending their time working with their clients and helping them get better and have those patient-centered conversations are doing a lot of administrative work. They're spending a lot of their time figuring out where the payment is. Do they have the payment? Can they offer this service right now? Is the funding stream drying up? And there's a lot of tap dancing and hard work that goes into this. And it's really, in my view, as somebody who focused on driving waste out of systems, it's a lot of waste in this system. So the three-prong approach we have right now is we're working with a consultant team from Tri-West on figuring out how to create a team-based rate that we would be able to get Medicaid to pay for fully, and also commercial insurance to pay for fully. So as you might imagine, this tool is a key component to that conversation. If we don't know how much we need, it's really hard to say to either Medicaid or commercial insurance, here's what we're talking about. Yeah, we want you to pay for these programs. They're evidence-based. We need all of the components of evidence, but their first question is, what's it going to cost me? So the tool has been really instrumental in helping us come up with a team bundled rate. And one of the things we've done in Massachusetts is we have 5 areas covered by our Department of Mental Health. So our state is broken up. And we've done a calculation for the team-based rate in each of those areas as a way to say, we know that the salaries in Boston are higher than, say, some parts of the western part of the state. So we have these sort of 5 calculations, and also based a little bit on, what caseload would we think we need to do based on the population in those areas, so that we can come up with a reasonable proximity calculation for what it's going to take to spin up the number of coordinated specialty care programs we need in the Commonwealth. And that's been estimated at 30. So whether we have 18 or 21, we're certainly not where we need to be. And we don't have really any programs that are fully funded for all of the component pieces. So we have a pretty big barrier in front of us. So we're hoping that this consultancy will help us in a negotiation with both commercial insurers and Medicaid. So that's one prong. And then the next prong is actually my personal advocacy, which is I've been an advocacy champion identifying sponsors in our state house to file legislation that would require coordinated specialty care and PACT programs to be covered through a team-based rate by a mandate to commercial insurance. And also here in Massachusetts, we have a variety of additional plans beyond just Medicaid. We have special student plans and special government plans. So the bill goes into all those details and says that every kind of insurance plan you might possibly have in the Commonwealth of Massachusetts would be mandated to cover. And again, one of the first questions is, what's it going to cost? So the tool has been instrumental in those conversations as well. And while the bill did not pass this session, it was filed for the first time in this session. I'm really happy with the outcome because it actually cleared 2 committees and made it to our Senate, Senate Ways and Means. Almost made it to a floor vote, which here in Massachusetts, it normally takes 8 years, 4 filings to get even a non-controversial bill passed. So that is kind of an extraordinary amount of progress for a first filing. So I'm working very hard right now on getting the bill refiled for the next session, which starts in January, and hopeful that we will get it passed. And for this audience, it's sort of national. You might be interested to know that several other states are doing the same thing. Illinois actually passed legislation 2 years ago. They were my inspiration for this idea. When I heard Illinois did that, I went, oh, snap, that let's do that. I believe Virginia and Maine currently are working on variants of this type of legislation, and there may be other states that are also doing it. So if you're in a state that isn't doing it, it might be something worth considering. And the final prong, and this is a really interesting question, and it kind of circles back around to the family journey, if you will, of trying to get care for a family member when your insurance doesn't cover it, is the parity experts nationally from the Kennedy Forum have indicated that not paying for coordinated specialty care is actually a parity violation. That similar to, say, chemotherapy for your child, they would never say no to that, right? And they wouldn't give you sort of half of the chemotherapy, nor would they try to do surgery without an OR nurse, right? So we're talking about the evidence shows you need all these components, and yet we're not paying for them. So we are pursuing the idea of trying to file a claim for the pieces of the program that aren't being reimbursed currently through fee-for-service. And then should the insurance company approve that claim, great. Now we have a precedent and we can push forward on that. But more likely they're going to deny it because their position is that they don't cover non-medical components. And then we would pursue a parity complaint. And we actually have locally a law firm that is dedicated to doing pro bono work around parity violations, who are willing to work with us in supporting anyone who would be able to file that reimbursement request. So we're excited about that idea as well. And one of the things about that is, for families like mine that are in that middle with employer provided insurance, some of them have pursued parity complaints about other things. And that's a big lift, right? You have to know what it is. 2, you have to know how to file it. 3, you have to pay for the care while you're waiting for it. And what happens is if you win your parity complaint, you eventually get reimbursed for the care, or you go without, right? So most families don't find their way through to pursuing a parity complaint, because if they can afford to pay for the care, they're going to pay for the care. They're not going to go pay for a lawyer to pursue a parity complaint. So we're really interested in highlighting the parity violation aspect of this as well. And there is a billing code today recommended by the Meadows Institute in Texas for doing just that. So that's kind of where we are in Massachusetts. We're pursuing a variety of different approaches. As an advocate, one of the things I try to highlight is we've sort of allowed the insurance companies to call the shots, partly because they have, but that it's time to sort of call their bluff, if you will, that if they want evidence-based programs, then they have to pay for all of the things that the evidence shows are necessary to get those outcomes, and to not sort of take the crumbs of what they'll give us through fee-for-service, but insisting that they make sure that we're able to have programs that achieve high quality and fidelity to the model, because they also get a second bite at the apple when they don't pay, and then the outcomes aren't what are expected. And the problem is you didn't have, say, the school and job supports that are so critical. So I think that's kind of what I wanted to cover. I think we want to open it up for questions at this point. Hopefully that was interesting.
Fantastic. That incredibly useful. Thank you so much, Monica, for that commentary. And thank you, Dr. Val, for stepping us through the tool and the logic behind that. Really interesting work, really important work. As someone as well who's got a very close family member with schizophrenia, my younger brother, can completely understand the issues involved and the fragmentation here that we're trying to solve. So we welcome questions to be submitted by folks who are with us on the webinar today. Again, use the Q&A box down at the bottom of your screen. Everybody's muted, so you can't talk except for our panelists. So type your questions in, and we will keep an eye on that. While that's happening, I'm going to take moderator's privilege and ask a couple of questions. I guess one question I would have, thinking through kind of how this decision tool may play out with payers, and I understand, the issues involved and the fact that they're likely to be more reactive in thinking about these novel payment methods. Do we know anything about cost offsets that might, be an incentive for payers to think more progressively about this kind of tool? So, in other words, what do we know about, are there downstream places where we see potential savings to more traditional medical care costs when we do a better job of financing the broader array of CSC services? And does the tool speak to any of those potential cost offsets in the work yet?
I'll take the first part of that. I won't speak to the tool if that's okay. First of all, I think payers don't pay because they don't have to. Their philosophy is any claim they don't have to pay is money in their bucket. And it is their preference not to pay. That's even true in property casualty, where they put a surcharge on you after you have a car accident, even though you paid premiums in. So they're in the business of keeping the money for themselves. So they don't pay because we don't make them pay. It's actually been proven, particularly, coordinated specialty care is a close cousin, I would say, to PACT. And there are decades of research that shows that PACT, worst case, breaks even. But in more recent times, it's shown to actually save substantial amounts of money in terms of hospitalizations and total cost, right? So one of the things that is sort of the dirty little secret is insurers don't care about total cost because they're not paying for the prisons, right? They're not paying for the police force. They're not paying for all the things that happen when individuals fall through the cracks and don't get the care they need. So that's part of why I went after legislation that forces them, because the incentives for them are small. But prior to taking this tack with legislation, I was actually working on what I call a pitch deck to show large employers why it would be to their benefit to have this benefit included in their mental health package. And there's no question that that's the case, right? It would save them money on total cost of medical care for that most likely dependent of their employee. It will save them money because, as there's research that shows that if you are the caregiver of anyone, a disabled dependent, an older adult, anything, the productivity hit in the workforce is about 3.5%. Yeah. If you're caring for someone with schizophrenia, it's over 7%. Right. And as a parent who held down a job during that time, I can tell you that it is a very distracting situation, and the only time you can make phone calls to address the situation is during your day job time. Mm-hmm. So but the research shows that. So from an employer point of view, where the productivity of their employee is like their number one thing, this is a real win for them. And then some of the folks in the field are talking about the total cost in physical healthcare costs to the family, because this doesn't happen to just the one person in the same way that it affects your employees' productivity. But beyond that, siblings, there's stress, there's way more medical costs when you look at the entire family. And then finally, people with schizophrenia are the most likely to be rehospitalized for a physical ailment, mm-hmm. In a short amount of time after discharge than any other population. So there are a lot of expenses that are hiding there that insurers aren't paying attention to, partly because they use a carve-out model. So they've got two different bottom lines, and they say, okay, this is what we pay on behavioral health, this is what we pay on physical health. And the fact that those two things are interconnected to their bottom line, they're not really looking at. So I would argue that helping them see that and see that it's in their financial best interest to do this is the direction, rather than offsets somewhere else, or it's closer than that. It's closer than that. And also evidence shows that their premiums won't go up. The Illinois law has a get out of jail free card that if in 5 years the premiums go up by, I think it was 1%, it might be 5%. I can't remember exactly, but there's a clause that says if your premiums go up by more than X, then the law is repealed, because no one believes that premiums will need to go up.
Mm-hmm. Wow, fantastic. really, really helpful. Dr. Ballard, would you like to?
Yeah, I can jump in. So thank you, Monica. You just gave an excellent lecture in layman's language, about why healthcare is, after all, a public good, and also, why kind of, the difference between societal costs versus costs from a particular stakeholder's perspective. So I would just say that the tool as it's designed now does not provide estimates on, like, say, cost offset from a health insurance plan's perspective. So it's largely a cost-based case rate payment, which, as I indicated, that there are two-fold objectives of designing this payment. One is to ensure that we adequately cover the cost of providing this evidence-based service to people in need. So from that objective, to meet that objective, we need to build the kind of the case rate payment based on the costs of delivering a set of evidence-based services. So it does not really take into account, okay, what kind of cost offset that we're expecting. And there is evidence from, the strongest evidence so far has been from the NIMH funded research efforts I mentioned, because one of the NIMH sponsored studies, a large national multi-site trial, it is a trial, so you kind of derive kind of estimates of reduced changes in hospitalizations and ED visits from that study. But our team, I'm a health economist, and this is certainly something that's of interest to us. But we have not been able to conduct that kind of study with compelling national data because it is just, the data do not, given how the CSC programs are implemented at a local level, and it's hard to come up with, and it's like real world implementation. Data wise, study design wise, it's kind of hard to come up with a rigorous design to really do a large scale study. But as Monica mentioned, it doesn't mean that there's no evidence because we know that mental health interventions, such as CSC, work and also generate many more benefits, or save the society a lot more costs than just reduce the healthcare costs. I'll stop here.
Very helpful, thank you. So we've got a question submitted in the Q&A now, asking whether there's more you could say, Monica, about the insurance mandate legislation that passed in Illinois. I was also really interested to hear that and hear your comments about that. And anything more you want to say about how that's designed, what kind of services are covered? The get out of jail free option is also quite interesting that you mentioned earlier.
Yeah, it's been a while since I read the law, so it's hard to keep details of legislation in my brain at my I'm a grandmother now, there's only so much fits in there. But basically it passed in I think 2019 and went into effect in January of 2020. I think that's correct. And they are still struggling with getting it implemented. So it ended up being this negotiation with the local, like Blue Cross Blue Shield and other commercial payers. And they are just at the point of signing contracts between Thresholds, who is one of the coordinated specialty care provider teams out there. And they were the advocacy champions behind the bill that, got legislative sponsors to get the bill filed. One of the problems with that bill is, ironically, of all things, they said, yes, we will cover coordinated specialty care at a team-based rate, except not for school and job supports. And then they said that they would cover PACT fully, which was really interesting. And I can tell you that I know one person who said that when he read that, he threw it across the room, because what is the point at some level of, propagating the problem of not paying for everything by explicitly calling school and job supports out? So I was very careful in the way we crafted the bill, the draft of the language of the bill, to try to do an end run around any kind of watering down like that of what would be covered, by specifying that it would be the standards of care that are set by the medical community, right? That it couldn't be, just sort of randomly pulled apart. So I think there's a couple of lessons learned, I would say, from Illinois, and one is that you kind of need to go for the whole thing, or it's not that helpful. The second is the devil's in the details of implementation. So the more you can get out ahead of that in your legislation, the better. And that is where this tool comes into play, which I don't know if that was available to the threshold folks. I'm not sure about the timelines of when they became aware of it, but it means that you can sort of, as you're negotiating through the legislative cycle, talk about what you are talking about monetarily. And then the other thing that's become really helpful in the interim is the fact that accountable care organizations, which work on a per member per month payment model, is essentially conceptually very similar to what we're talking about, right? You're going to do a per member per month payment for, now the membership isn't in the insurance policy, it's in the coordinated specialty care program. But conceptually, people are getting a lot more comfortable with this sort of idea that the providers are deciding how the funding gets spent to create the best outcome as possible for the individual patient, right? So a few different things there are helpful. And I'm not sure I fully answered the question about the Illinois legislation, but those are the things I remember. I do know that get out of jail free card of the premium rate was an addition. It was a negotiated thing in order to get the bill passed. And in Massachusetts, our legislative sponsors opted to put it right in. They thought that would make it easier to get the bill passed. So those are the kinds of negotiations that you figure out with your local legislators who are willing to work with you on something like this, is what do they feel like increases the odds that they can get it passed through their championship of it in the State House.
Yeah, I think that's very, very clever, and also very clever component to include in that. Also means that somebody's got to study the impact of that insurance mandate on premiums and other outcomes as well. So hopefully we'll be adding to the evidence base as Illinois and hopefully Massachusetts and others go this route with legislation. So another quick question I wanted to get to submitted. Oh, sure, yeah.
I just quickly add that so the Illinois, Mark Hagan, who is kind of the leading provider stakeholder in Illinois, and the Threshold, which is Mark's organization that spearheaded the effort in Illinois, used our tool. And when I said that the provider stakeholders were using our tool in a different way than we expected, I primarily had them in mind, because they were using the tool to kind of get a sense of what their bottom line would look like. They kept it to themselves and they did not review it, the different scenarios that they played with to whoever they're negotiating with, I guess the payers in Illinois, but that's how they used our tool. And he was Mark was a guest speaker, in one of the research progress seminars that we had in the past.
Fantastic, that's great. So one of the questions I do want to get to from Lynn Nichols asks about whether this have you considered expanding this model to other types of behavioral health conditions beyond early psychosis and what that might look like?
Monica, you wanna, yeah, go
Yeah,
ahead.
is the question about payment or is the question about medically designing programs differently? I'm not quite clear on the question.
Yeah, I don't know exactly. I might say that maybe the payment model, could this payment model be expanded to other types of behavioral health conditions where you have this problem of needing to coordinate services that can expand beyond the boundaries of traditional, what's traditionally considered medical, medical care.
Yeah, so certainly my bill requires coverage for both coordinated specialty care and PACT. So it's not just early psychosis, but it is both of those are targeted at folks with psychosis. To
Right.
the degree that here in Massachusetts, we have a lot of peer supported elements like recovery learning centers and recovery coaches and a peer respite. And all of those are funded today through our Department of Mental Health, through the Medicaid block grant primarily. I think. I shouldn't say I know that. I don't know that. That's my assumption. In terms of what kinds of other supports people need with other types of illnesses, like I don't know how to speak to that, but I don't see any reason why whenever you would benefit from a multidisciplinary team in some capacity, that this wouldn't be a precedent if we can get this to say, we're proving that this kind of grouping, and it's kind of an interesting question more in general. As I say, I've had a family member who had cancer and they were offered a cancer support group. Why do we think it's so strange that people, and that was paid for by their insurance? And I'm like, why do we think that's so strange that people with a psychiatric illness might need a support group? So I think there's lots of room for growth, but somebody like me has to rely on sort of the treatment world coming and saying, and that treatment world might be a peer, a group of peer programs that get, put together and need to be funded or whatever. I'm not saying everything has to be medical or include medication, because I don't believe that, but I do believe that people benefit from a lot of things that aren't traditionally considered medical, and that this could become a precedent. But since I don't know of where else this would apply, I can't actually say anything else about it.
If the question were about the research approach, like the approach to developing, the thinking of developing those case rate payments, yes, definitely. So my own work in, aligning payment was behavioral health treatment started with collaborative care of depression or anxiety, common mental health conditions in primary care. So CSC is kind of a second type of interventions or programs that we have worked on, and currently our team are developing some work in the area of peer, how do we finance and cover peer support services in substance use disorder treatment, and especially OUD treatment, which is, as you all know, a priority now in addressing the opioid epidemic. And it's not just covering the cost; it's also covering it in a way that makes sense. Because as we spoke with peer support service provider organizations and agencies, and they were, some of them had those fee-for-service billing experience, and they were just referring to that experience as turning our team into a billing. This is what fee-for-service does, and this is totally at odds with what the intervention, the program is intended.
Fantastic. Well, we are out of time, but thank you again so much to Dr. Bao and to Monica Luke for sharing with us this great work. If you want to follow up with this research team,
It looks like we lost Glenn, but thank you very much to everyone on the call today. Thank you for joining us. We will send out a link to the recording and the slides to you all afterward. And if you have any questions, you can follow up directly with the presenters today. Thank you again and have a good day.